So, on today's podcast, I'm speaking with Fawz Kazzazi. Fawz is a core surgical trainee at Imperial College London, and he's also studied medicine at Cambridge University. He's also doing a master's in medical law and ethics at Edinburgh Uni, and he's recently published a paper in the Journal of Future Medicine setting out a classification of AI for healthcare. Fawz, welcome to the podcast.
Hi, Zach. Pleasure to be here. I'm very excited to discuss all things medicine and AI and see where we go with this.
Well, that's fantastic because this is such a big topic, and I kind of have, no idea where, the conversation could go. It's that massive. And, I read your paper, which you published, and you were kind of talking about the framework that's been used for self-driving cars as a way of applying that to the medical field to help us know what level of AI we're at. I was just wondering if you could, tell us a little bit about that paper and, how you published it and what you were trying to say.
Yeah, sure. So the paper came from the idea that if we move towards a state of AI known as general AI, where the tool or software can achieve anything or think anything that a human can, then what separates that software from being classed as a doctor or having the title of doctor? And it came into this sort of ethical and value principles argument of what it means to be a doctor, what are the aspects of human level medical care, and what do patients and clinicians value. And then starting from that, sort of broke it down a bit and looked at what's already been achieved. And when you look, you already have software that can pass medical finals tests, medical school finals tests. So you have to ask the question, well, if that software could pass an OSCE, why would we not call it a doctor if it's reached the professional standard of any FY1 up and down the UK? So when looking at that, I then began to realise that there was no homogenization or standard across specialities, across tools, across new technology. And let's see what other industries have done. I came up with this 5-tier or 5-level structure that looks at the key aspects of human level clinical care and tries to get whoever we can get on board or influence to set standards of care and set parameters for aspects of potential AI care. So you're looking at what knowledge is acceptable, what level of safety is acceptable, what level of emotional care is acceptable, and then what you do is you put that on levels of independence from 1 to 5. So you've got your level 1 tool that a lot of us probably already use, where we can automate a score out of some set parameters, and it might help us stratify a patient, but in itself, it's just an adjunct.
And that's sort of analogous to like the cruise control on a car. Is that
Exactly.
what we're talking about?
Exactly. So it doesn't really, it takes an input and there's an output, but ultimately you turned on the cruise control, you set the rate, you decided to use it, and you stop it, and you're completely in control. And then it moved up into what I classed as level 2, which was where you get some sort of greater independence. And this is the sort of area that lots of AI right now is targeting, and it's this augmented intelligence rather than artificial intelligence. And that you're looking at your scoring, triaging tools that may have a very small area of independence. They may say, look, Dr. Hassan, there are 10 patients in this department. Patient X, Y, and Z need to be seen in the next 20 minutes, and the other 7 can wait. And you trust that software, and you say, okay, I'm going to see patients X, Y, and Z. Mm-hmm. And then moving up, it becomes a bit more about the emotional care and the holistic care. Will the tool consider the patient's, what's best for the patient? Will the tool consider the patient's race and try and eliminate the biases that have already been established in the data sets? What level of independence does it have? Is it like an SHO or a registrar? I need to speak to a consultant. Are all outputs consultant validated? Or is it entirely on its own? Is it level 5? It reaches all levels of safety, knowledge, emotional care, and functions independently instead of a doctor. And trying to get to that framework has been a really fun journey, working out regulatory law, you know, ethics, philosophy, and trying to piece it all together in something that ultimately looks simple but takes a lot of effort.
Because when you talk about sort of level 5, I think, or when people talk about AI in the media, I think they're thinking about level 5. They're like, this software is going to look after you. It's going to do all the things that a doctor can do. But it doesn't sound like we're there yet. I mean, do you think that it's somewhere that we could go? And when do you think that might be?
So when you keep your ears to the ground and you try and listen to what the experts say, some predict there's one gentleman, and I think he works at one of the big firms. It's either Microsoft or Apple, and he's renowned for having something like an 80% success rate for predictions. And he says that he suspects a general AI, this AI that can do or think anything, think probably better than do, can think anything that a human can, or can do everything to a human level of intelligence for decision making. He thinks that will be achieved in 2029. That's 10 years away. More conservative people say 10 to 20 years, 10 to 30 years. And that's when you've got the technology, or the technology is emerging. And then you need to think, well, how soon before we apply that? Does it reach clinical standards and things? So it depends how quick people want to onboard this. Depends how good their publicity is. Depends how good the health, how ready the healthcare system is. And then it also depends on, and what is actually terrifying from all of my reading is there's no research on what patients think about AI. Not a single paper on PubMed. No single paper that says patients would quite like AI, or patients would not like AI, or patients would actually never go to an AI doctor, or patients would love to go to an AI doctor. There's a complete paucity of the literature. And so it's a huge unknown. When will the technology be available? Probably in 20 years' time.
And it sounds like what you're saying is that we need to start preparing for that, because it could be a relatively soon, in terms of the evolution of the health system, that this could be happening. I'm just wondering about, with the potential benefits, of this level 5, and it doesn't sound like we're there yet. So this AI intelligence that can pass the OSCE, it can't do all of the other things that that a newly qualified doctor would be able to do. I'm guessing, I'm just wondering where you kind of sit in terms of thinking whether the benefits of AI are enough to sort of justify all our efforts to try and innovate in this field.
So I think back to that's a very, very good question, and it's a very pertinent question. I think sometimes you just have to look at the tools being developed. So, I mean, when you think of narrow AI, that's AI designed to do a specific function. There is some exceptional software out there that does things very well, and it already slips into the current NHS structure. So I think of one of the colleagues that I work on. I work for a firm with. She designed a software that uses AI called See the Signs, and that helps GPs identify red flag symptoms and refer patients onwards for 2-week waits. That is great software. It works. It's easy to use. It's what you call user experience and user interface led. It's very simple for people to use, and it's spreading around the south and southeast of London. But then you look at other tools and the more general things, and you start to wonder, is it worth it? Like you say, do you want to change the whole system? And like I said, do patients want it? And there's a Lancet paper from 2001 that actually shows, well, patient outcomes, Lancet review, from 2001, shows patient outcomes are better with happier, nicer, kinder doctors. And no one knows why. And that's not just patient-reported symptomatic / sign outcomes. That is patient outcomes, mortality, morbidity, better with happier, kinder doctors. So I think we need to not fall into the thinking that the tech gurus and tech bros often try and get us down, which is it's all about efficiency, it's all linear, it's all X is 10% more efficient than Y, therefore we must pursue it. It is more cost efficient. I don't think we've delineated everything too well yet.
Yeah, and it sounds like if we don't even know what patients, are going to think about this, I mean, do you have any idea from, just your experience as a junior doctor about, you know, it might be one thing the AI sort of helping the doctors to, stratify risk and decide which patients to see. But then, if you're the patient that's not getting seen because of that algorithm, is that something that you're happy with? Or, are you happy with the decisions being made by an algorithm instead of the doctor, being the final check on it? You know, what's your sense of what we need to think about?
So that is a very, very like huge topic, and it's something my law research dissertation actually focuses on as well. So you've touched on two very good points there. One is, how is PALS going to work? How are patients going to be able to complain? Do they complain against the hospital? Do they complain against the doctor? Do they complain to the software company? And the second is the duty of care. Do software companies have a duty of care? This is entering firmly into my dissertation territory, and it's, do software companies have a duty of care to patients? If I'm a clinician, um, am I a sufficient intermediary to completely absolve the software company of their duty to the patient? What if their algorithm is complete rubbish and I start using it because it's been validated on things, and then suddenly it doesn't work in practice? And that happened with IBM. IBM released a software that was meant to decide management plans for cancer patients called IBM Watson. And it was done entirely on test cases from Memorial Sloan Kettering in the US. And what they found was, in practice, I mean, it didn't work. And when you moved it across continent to South Korea, their experts completely disagreed with the suggested management plans. When you moved it into places that didn't have specialists, they fell for this thing that we call automation bias, and they just assumed it was IBM, it's great software, let's just do whatever it says. We have a 100% concordance rate with the software. But then obviously when things went wrong, patients didn't know who to complain against. Do they complain against the algorithm or the doctor? And we haven't established that. It's not been established in the UK. What is the extent of the duty that these software companies owe patients? And then more so to what you're saying is, some of these software algorithms actually perpetuate socioeconomic and racial biases. They're based off a data set that is already has a series of biases in it, and they amplify it. So some work's been done on management options for benign prostate hyperplasia. And what you find is that the higher the socioeconomic class of the patient and their education status, the more likely they are to have surgery, because the algorithm has historically taken all the patients of a certain demographic and said, these are conservative, these are non-surgical conservative management sub-cohort of patients. And then all you do is you just widen that gap between those that are the most well off and those that are the least.
It might be worth explaining that a little bit more, and maybe you can correct my understanding about this. But like the reason that you get that bias is, from the data set, is that you're using what's called a neural network, which is basically you're taking like your training data set, and it's looking for patterns based on you tell it, okay, these people are for conservative management and those people are for surgical management. But then the neural network sorts out, and you don't really know why it's choosing the ones it's choosing. So it's a black box, but the data is only as good as what you put in. So if your data set is small, then and if it's biased as well, then that's going to it's going to learn a very narrow view. Your neural network's going to learn very narrowly about what to do. Is that what's going on here?
That's absolutely it. If we take the example of the big do not resuscitate order discussion that's happening nationwide at the moment after the COVID pandemic, what's clearly arisen from that is a lot of clinicians have an unconscious bias towards not performing CPR on people just because they're elderly, which I hope we both know is not an indication to not perform CPR. So if you then took a historical data set lasting a year, the algorithm would learn, well, if they're elderly, then maybe they're DNAR, they're not for CPR. And that's our unconscious bias being amplified by the algorithm. Because to the algorithm or the neural network or whatever tool they're using, it just sees success and failure. and it knows that certain parameters lead to success and certain parameters lead to
Mhm.
failure. So yeah, you're completely right. It's just it used incorrectly. It's an amplification tool for widening, inequality gaps.
And just to go back to something you said, because you mentioned about, well, we don't know, we've not worked out who's actually responsible when something goes wrong, and if the algorithm's prone to bias, well then you're kind of left thinking, well, what else could go wrong? Where do you think we should be starting that process? What's your idea about what should happen if something goes wrong because of an AI algorithm?
Yeah. So um, if you look to the case law, there's a case of called Dickman versus Caparo, and out of that came the Caparo test, which is to establish if someone has a duty of care to someone else. You have to first work out um, were the risks foreseeable. Is the first test. The second test is there a proximity between the two parties, and the third is it fair, just, and reasonable to impose a duty of care on this individual. And to completely surmise, my next phase of research, because obviously it's a huge discussion. When it comes to reasonable, a lot of people hide behind this black box of we don't know what the algorithm is doing, therefore we can't predict any risks. But that's just nonsense, because when they're advertising and publicizing said technology, they firmly tell you that it has a sensitivity rate of 98% and a failure rate of 2%. So they know that in 2% there's a risk, and to me that's foreseeable, and so they should be mitigating that. And then when you think of the proximity, I mean, we go back to this whole idea of an intermediary agent. I mean, if we implement it in 20 years, I can imagine most, doctors being savvy enough with technology to know when the AI is messing up and be able to troubleshoot the AI. So it creates a reliance on the software developer companies. So for me, that completely eliminates
Mhm.
the clinician as the third party, and the proximity between the software company and the patient aligned, because the software company, by the hospital using their software, has created the environment in which it's used. They've set the parameters of safety. They've set the conversation. And then suddenly, if something goes wrong, they say, but you signed some contract terms that said that you can't do that. And when you look at the contract law as well, you can't just completely absolve yourself with a little contract term, in a terms and conditions that we quickly click agree to.
Mhm.
And there's a famous case where there was a gentleman who did a survey report, surveyed a property, passed it as safe. Someone purchased that property from the bank. Chimney collapsed. They lost a lot of money. But in his contract with the bank, it said, "Oh, I am not responsible or liable for any issues that happen as a result of my report." And the court said, "Well, this is complete tosh. That's not a valid contract." So you've got all of this, and you've probably seen it in the clinical apps you use. How many times you have to sign a disclaimer saying this app, any poor clinical outcomes that come out of this app are not the responsibility of the company. Well, if that's the case, why did you design the app? I wouldn't go around designing a football. I wouldn't tell you I've designed a football. It's better than all footballs in the lab. It's just as good as Champions League football. But if you kick it and don't score, or if you kick it and it breaks, it's
Mhm.
not my responsibility. I'm just selling it to you as the next best football, and you'll always score with it. Do you know what I mean?
Yeah, there is this sort of relying on clinicians to be the final check for still not at that level of independence yet. So again, back to the car analogy. It's like the Teslas. Like it can drive on the road, but you're supposed to still be there to take hold of the wheel if something goes wrong. But you're right. I kind of think about my own experience, and I think, well, if the trust has decided, right, this is the app that you're going to use, and this is what you're going to do with it, I think, especially as a junior doctor, it becomes very difficult for you to say, well, I'm not going to follow the trust policy for all the junior doctors that are in my position, and make up a stink, because um, you know, well, I don't think it would end very well. Um,
Yeah, and do you
and
not think it's like a paradox in design? You say, "Oh, I'm designing this tool because humans are imperfect." However, said imperfect humans are the final check and purveyor of my tool. And you're like, "Oh, what was the point of the tool then? I could have done it on my own."
yeah, yeah, it's all so. What do I think about this? I mean, tell me what you think about what I'm going to say. So, I've been reading Eric Toppol's book about AI in medicine, and what he's saying is that, if we can use AI to offload some of the routine work, the sort of the thinking work that's very dull, then it frees up the doctors to think more about when the algorithm's not the appropriate thing to be using, or to have more of that empathy with patients that you talked about. Do you think that that's maybe a way we could match up the growth of AI with also the patient safety?
I mean, realistically, that's undoubtedly the way it will get introduced in the first instance, is that it will take the more menial, simple tasks, and then that will expand and expand and expand. But like I say, it's a melting pot waiting. It's waiting for the big case, the Baogaba, where a doctor relies on it, and then the patient brings a case of negligence against them. And people always, they cut corners when it comes to things worth a lot of money. And I have fears for that patient safety. But in terms of where I think it would be best placed, I mean, I think some of these tools would be great for, say, I see, Mrs. Smith, an 80-year-old, and I see her and I say, wow, I think she's a good candidate for surgery, but she could be a better candidate. I think it'd be amazing to plug all her information into a tool, and that tool says, well, Dr. Fawz, if you want to make her a better candidate for surgery, you can optimize her by doing this, that, and that. And that would be a great way. That would be a perfect example of this augmented intelligence, where it's not replacing, but it's just enhancing the way we treat our patients. And that is a good way that the company is trying to get away from the liability as well. It's not a decision maker, it's a decision enhancer. And if they stick to that, then, by all means. But if they're comparing it to clinicians and as, a valid management tool, then they need to stick to their guns and can't go hiding when
Can't have it both ways.
Exactly, yeah.
Maybe that's a good point at which to start talking about regulation, because I know you've mentioned to me about Elon Musk saying that to enhance AI innovation, we need to deregulate completely and just let companies do what they need to do in order to get this going. And I suspect that you're not in total agreement with that view. What's your thoughts on it?
I mean, the information gap between these, tech giants and our own regulators is terrifying. We still, although these tools are being trialed and implemented in places, don't have any guidance from the people we would expect to have guidance from. We don't have guidance from, the CQC. We don't have guidance from the GMC. We don't have guidance from NHS Digital or NHSX. Everyone keeps doing these great prospective reports on, AI will be great for efficiency and cost savings in the long term, but we've got no standard operating procedure for implementing it in the short term. And
is that sort of, it's just not on their radar, as an issue yet, or is it that they don't actually understand how far ahead the technology is becoming and the need to keep up?
I think that they probably appreciate and understand, and they have expert, consultants that tell them these things. But I just think that they can't, by process of their bureaucracy, is way slower than tech. I mean, you've seen how quick these are risk takers. Technology are risk takers, and all of regulation is risk averse. And you just look at, you look to the US, where they just had this recent debate on deep fakes, where there's this fear that in the next election, deepfakes will be impossible for the population to tell whether videos are real or deepfakes. And you had senators like AOC trying to push for this technology to be banned, and everyone knows that it's going to be a disaster once deepfake becomes widely available. But the regulators and the lawmakers don't have control over the tech giants. They imagine if they tried to do that, they would cause upset. The reality is we live in a neoliberal capitalist state, and so the things making the most finances, innovation, and intelligence are going to always be able to dampen down the regulation.
So it sounds like you're calling for, or what you're wanting is for the regulators to be, a bit more quick thinkers about trying to stay on top of this and to maybe try and get ahead of what some of the issues are going to be. So I'm just thinking about what those, issues might be. We've spoken about some of them, but do you think there's any other special considerations we should have when applying AI to a medical context? Like, what's special about medicine that we'd really want to think about?
Yeah, so my two priorities, I think, for any regulator or group is patient safety, number one. That is the priority of all, healthcare professionals. And two, clinician safety. Patient safety is obvious. And I have no doubt that some of these softwares will be able to, in the long run, improve patient safety. They'll be able to reduce some of the silly errors that humans make. But then I don't think we should have patients that allow the algorithm to learn. I think that is a ridiculous notion. I think that patients are not volunteers for future patients to receive more optimal care than their own because the algorithm was still learning. But then even by virtue of having that opinion, well, what's the standard that I accept? I don't know, because no regulator or there's no framework of an acceptable standard. So patients may suffer. And then I look again to clinicians and I think, well, in the situation where a harm could come to a patient, how is a clinician going to be able to defend their actions? I mean, you look at all the different disparate bits of case law, and you can't ignore any information. So if information comes to my desk, I'm not allowed to ignore it. I've got to explain why I didn't act on it. If a senior gives me a decision, I have to follow the decision of the senior. Well, if it's AI, is it my senior? Is it my colleague? Is it my junior? It technically can assimilate tens of times as much information as me. Does that mean I have to listen to what it says? If its output is like a very rare disease, and I've seen DVT so much, and it tells me that the actual cause is this very rare thromboembolic disease. Do I go with that, or do I go with my clinical experience, where I've got the impression? And then, fair enough, that you might side with the AI, you might side with the clinical experience, but it's uncharted territory. Where is my regulator telling me, we'll defend you if you side with either? We think you should side with your experience over AI for the next 5 years. We think you should side with AI over your experience. Where is that? Why are we implementing it without any of that?
There's a number of theoretical sort of problems that you're talking about. Like, one is like, how do we know that the AI actually is going to do a good job when we put it in the real world? Like, how do we judge when it's good enough? And then also like a sort of element of patient choice. So, do patients actually want to be involved in helping develop the algorithm? I imagine some would be. Imagine some people would be really keen for that, and I imagine other people wouldn't be. Not just about whether the algorithm's used on them, but also like whether their data is used. What's your feeling about the use of data?
There are lots of aspects to use of data.
It's such a big topic, isn't it?
I mean, you have to look at the ethics of sharing data that was, confided in a healthcare service, and whether you first are able to give that data away, be it confidential or not, because you could identify anyone from their health data. I think if you had enough of my health data, height, weight, blood pressure, ethnicity, you'd probably narrow it down to 5 people in London. So that's the whole conversation. It's a conversation about who do you share the data with? Why do you trust certain firms over others? How are the contracts going to be allocated? Then you have the whole financial argument. Well, how much is 5 million patients worth of data worth? Is it really worth a licensing agreement where I get a free use of, where the NHS gets free use of a software for like 4 or 5 years? Or is it worth billions of pounds? Do I have to sell it to them? If I sell it to them, do I have to share that funding and proceeds with the patients? And it comes to this. There's 2 key medico-legal / ethical principles that I think apply in the data aspect. And the first is the John Rawls social contract theory. What is the social contract of living in a society where my data is shared? What does the population agree with, and what do they not agree with? You know,
That's interesting because I was thinking about something similar. So I was thinking, well, you pay tax, you don't really have a choice over whether you pay tax or not. You have to give your finances, and I kind of think, well, if we're willing to do that, then should we not also be willing to give data to an algorithm that might make everybody's healthcare better, especially when we know that needing large data sets is like an essential part, and the NHS is one of the biggest data sets in the world.
exactly, that's exactly it. And we're likely to see this idea of social contract change by the time our generation becomes 40, 50, 60. We're well more accustomed to technology. But then you have to look at our current practice as well. And do patients really know that doctors are auditing their results and presenting them at conferences? Are patients really aware that that's happening? And when they are, why do they trust doctors and not third parties? And if they do trust doctors and not third parties, is it right that we then break that trust by sharing all their data?
Mm.
And this it just comes back to one of my earlier points. I mean, this is not a simple. It's not a linear. None of this is linear. This is all very much fluff, grey zone challenges that we find ourselves in this transition period between totally technology and AI reliant and moving over from a society that 20 years ago barely had broadband.
It's quite something. It's quite overwhelming actually, because the sense that I'm getting speaking to you, Fawz, is that there's so many issues. We know what the issues are, but we don't know. We haven't got the foggiest about how we're going to sort them out. We don't know who's going to own the data. We don't know what the process is going to be. We don't know what people want. We don't know, what people, how much choice we should give people, or how much information we should give people. So it all sounds like a bit of a mess. Really. Um, how do we sort it out as the next generation of clinicians?
So, I mean, really, we've got three options. So, one is we slow down the tech. The reason we haven't had a chance to think about how to at least try to answer these questions and design, formative, normative, frameworks like my own is because we haven't had the time. We're a lot slower, Well, even if we think about it a lot, we need to go through all these processes that we've established now for enacting rules. And so, if we can't slow down the tech or speed up our current processes, we're going to have to be reactive, which is what happens in a society that doesn't have a constitution. Is that the law gets built around the cases that arise in the civil courts and the criminal courts. So maybe we just plod along, accept the risk, and then when issues arise, try and address them. We're looking at this all the time currently in the pandemic, where people are like, oh, well, let's dehumanize the deaths of certain populations and open up. No one cares if not no one cares, but we have to accept so many deaths to open up the country. Well, is it going to be the same thing? We have to accept so many deaths to implement artificial intelligence in medicine. And then the third option really is taking back some control and making sure that the channels in which we implement it are entirely patient-led and then healthcare professional-led. And there's this big key thing that I believe in called accountability for accountability for reason, or accountability for reasonableness. And it's that at every stage we are accountable, or someone is accountable, or something is accountable for any issue that arises. So we say we're going to implement this AI, but the software developing company and the hospital are equally accountable should a harm arise to a patient. Mm-hmm. Patient can take the risk and go ahead with the procedure, the management plan, knowing that should something happen, at least they can be remunerated or something for their loss, their financial and or personal loss. But that's the only way I can see it going forward, is to start working out how we're going to implement it in a safe, accountable way.
Yeah. It kind of, so the three options that you talked about, I'm kind of thinking, well, it doesn't sound to me very likely that the tech is going to slow down, because there's too much, there's too many incentives for companies to be in this space financially. There's also too many incentives for doctors at our level to try and contribute to this area, because everyone knows that health tech is like the next thing that's going to take off, and if you want to make an impact, better learn about machine learning. Speeding up the processes. I think I'd like that to happen, but I really sort of worry. You talked about the pandemic and about how reactive we've been. I'm not convinced that's going to happen either. So yeah, maybe we are going to go down this sort of reactive route, and I kind of think that's maybe the less good of the three options. What do you think?
Yeah, I think the reality is we'll end up down a reactive route, and there'll be a series of foundation cases, cornerstone cases, which we can then accelerate all of the bureaucracy and regulation through. There's going to be mistakes, and people will need to take responsibility for those mistakes, and then that will dictate how we do things. And you just have to hope it's not going to be a big mistake, and that everyone stays safe. And I fully realize that all of this is caveated with, maybe in its implementation, it's so much better and safer than human level doctors. Actually, up until that one mistake, we've saved or improved the lives of 50 to thousands of other people. But we will wait. I think we will wait for the landmark cases, and we will work out what happens then. And back to your original point, I think Jeff Bezos has a famous quote as well about he thinking that healthcare technology is the next biggest industry. As well, I think he states that as well.
And the other thing that sort of sticks out to me about this issue is that there's not really an opt-out. We're all sort of along for the ride. And whether you're a patient or a doctor, or a politician or a policymaker, AI is kind of coming, and there's not really a lot we can do about it.
Yeah, I mean, look at our phones. I mean, look at the amount of data that we agree to with cookies and all this stuff. And what's interesting and refreshing to see is I think more companies are being conscious of the way our data is being shared. The latest Apple update gives you an opportunity to not track between apps, and that is a huge liberty that we didn't even know we needed, or know. I'm sure there are lots of people who didn't even know that there was cross app tracking, and you just have to hope that at some point the tide will turn, or everyone just stands to benefit and becomes complicit in what will be the great data gatherers.
Mm-hmm. So a lot of people who will be listening to this podcast are sort of medical students or early career doctors and other healthcare workers as well. If they're sort of wanting to get into this space, if they're sort of like you and like me, worried about some of the potential impacts of AI, I mean, what kind of space should they be getting into? Should they be going to work for the health tech companies, or should they, be getting more into the legal framework, or sort of being between, the ethics field and what do you think are the interesting places that people might make an impact?
Yeah, that's a great question. And what I always tell people is to do something, it's going to sound incredibly basic, but do something that you enjoy, but is also useful. So I think in current climates, we've all fallen, myself included, fallen into the trap of portfolio medicine, spending thousands of pounds on masters and courses and things in something that we don't necessarily want to do, that's just going to enhance our portfolio. So I always tell my colleagues and things, well, if you're about to spend £9,000 on a master's, have you thought about spending it instead of on one course, on one that you can actually pivot and learn more about the passion that you have for social inequality through technology? Have you thought about maybe doing this ethics course instead? And there are lots of them. And they're like, oh, actually, I didn't think about that. I'm like, yeah, and if you ever wanted to pivot into a different industry, be that policy or tech, you are now qualified at a master's level to use that degree, and you can take a good role where you can make a difference in these institutions. rather than just sticking to something that you may or may not be able to use within the NHS. If you look at students, there are lots of great think tanks that they can join, student think tanks. They can get involved with good projects. And then I think that, I know that there's lots of free coding academies. I think one is actually called Free Code Academy that lets you do courses and enhance your online CV. And organizations such as WHO look at these online CVs and cherry pick people out of it based on their background. So what I would say to people is find the bit of it you enjoy. Do you want to be a change through the coding and technology aspect? Well, go and work towards that. Do you want to be looking at policy? There are great opportunities in policy. Really dive into them. Join the groups. Join the societies. Or do you want to do something as a career? Well, look at the options that you have. You're a very qualified individual. You will be a qualified individual by virtue of being a medic. You are a very rational thinker. You're an efficient thinker. You're a hard worker. You're all these great things that would be a joy to any career you decide to take.
And what do you see for yourself, Fawz? Because I know surgery. There's a lot of interest in the AI field. Is that something you want to keep exploring? What's next for you?
So I had to tell you before this episode, I think I'm going through a protracted existential crisis. But I suspect I'm sort of following what I enjoy at the moment, and I'm trying to build up. I did a lot of work in policy, and I found that the shortfall of policy was I didn't have the legal expertise to be able to implement these policy suggestions in law, or at least understand how they could be. And so I've worked hard to get the economic and policy understanding through further education. Now I've got the final sort of part of my trifecta, which is the legal knowledge as well. And then I don't know what I'll do with it. I might decide I'll probably, the default is surgical training, and then I'll see what opportunities arise, see what I enjoy, see where I can make a difference, and then take it from there.
Well, I think with that extra knowledge, you're going to be somebody to watch in the years to come, and obviously, massively passionate about this issue. One question I always end on is, whether there's a book that sort of influenced you on some of the topics that we've been talking about, or you think people should go and read.
That's a great part. I've been doing more reading in this last 2 years than I have in my life, I think. Just by virtue of having a commute, it's quite relaxing. I never thought I'd be reading at 6 in the morning. I'll tell you that exactly. I never did that. I never did that at uni. I didn't do that at uni. But yeah, there's a great book in terms of fiction. There's a great book called The Black Cloud, and it was written by the gentleman that gave the alternative theory to the Big Bang Theory. When you know a bit about his history, it's a big, screw you to all the Nobel Prize winners that won for their Big Bang Theory, and he didn't win. And it's a great book because you read it and you only get to his biography at the end, and you wonder when you're reading it where all this amazing physics is coming from and how they could be so accurate. But that's a good one because it introduces you to how abstract some of these ideas could be. I was just trying to think. I knew I'd just finished a book not too long ago that I really enjoyed, and it was. So I've got 2 recommendations off the back of my bookshelf. All right, I just went to see what I just finished. One, if you want a really soft and sappy book, but you'll get to the end of it and question, why you're so emotional, and it'll make you inflect a bit on your own life, is The 5 People You Meet in Heaven. And that's a really good book about an individual that revisits his life. And it's just quite good for the self-reflection of the original question of what do we want to achieve with all of this. And then if you want to look at sort of the concept of human self-indulgence and perhaps apathy towards others, I really recommend A Picture of Dorian Gray by Oscar Wilde. I've just finished that recently, and I mean, it's no surprise, but it's phenomenally written. It's probably like the ultimate soft boy book or something. But it's a really good read for a bit of insight into the selfish world of humans.
Oh well, thanks, Foz. It's been really, really good speaking to you, and yeah, thanks for being on the podcast.
Thank you, Zach. I mean, it's been great watching you do this. It takes a lot of your time. You've been so great at helping me and preparing me for this, and I'm sure this will go somewhere very good for you as well.
Right. Well, all the best.
All the best.